Good morning. Hope you can hear me. My background is I'm the manager of the Surgical Intensive Care Unit. And for many of you know that patients in the intensive care unit probably have the highest risk of hospital-acquired infections because of the nature of their problem. They're on ventilators. They certainly have a lot of devices and open places, Foley catheters, IVs, that put them at risk for infection. So they are an extremely vulnerable type of patient. I've always worked with ICU patients from the time I was 22. 30 years I've been in nursing. And I always remember a first quote someone gave me and said, "Our job is to protect the patients from anything while they heal themselves." And so what I always remember is that quote is that we have to protect them. It's our job to protect patients because they're very vulnerable. So I manage a surgical intensive care unit. It is a relatively small unit for some things, but we have a huge amount of opportunities for hand hygiene because it is an ICU and they are surgical patients. It's a 12-bed unit. I have 36 full-time, they call them full-time equivalents, which I refer to as my nurses. We have 3 clerical staff, but then I have hundreds of people that come through the ICU. Infection control practitioners, transporters, food service people, physicians, millions of people that come in and out through the ICU that don't actually sit under me. They are not my employees, so I don't necessarily have any authority over them. Not that I don't wield some power, but I don't have any legal authority over them. It is an open unit. Open units are an ICU where some closed units, like we have some closed units, like a burn unit, where they only take burn patients. An open unit will take overflow from medical intensive care patients, from cardiac, from any of the other areas within the hospital. Typically, though, because it's surgical, we will get patients that have been to the operating room and have a surgical wound. It could be from transplant, which puts an additional risk of infection because they're on immunocompromising medication. So, again, another high-risk population. It's taken a long time, but I have a high-performing staff. It's been a long process. About the time we started electronic monitoring, we also started to work on a culture shift. We moved our unit to another place within the hospital, and I was released from 4 other jobs. And that's when actually I could shift the culture because I could focus on one thing, and that's the staff, and I think that's been pivotal. Just to give you a little more idea, we're a unionized environment, and if you know anything about that, sometimes there can be adversarial situations when you have union versus leadership. And again, that was another hurdle I had to overcome, and it's been very successful. And our culture was not always so great, and if many of you worked in a hospital know that there's some work environments where people are less than friendly, they're bullying, they're challenging to work with. In fact, one quote from a nurse who had to float to our unit said, "I'd rather drive my car into the viaduct than float to your unit." So I thought, oh my God, because I surveyed everybody who floated into the unit to get their opinion on that quote always sticks with me. Because I thought, this has to be fixed. There's got to be a way to fix this challenging problem. And so I came from a standpoint of what can we do to change the culture? Not strictly for improving quality or improving hand hygiene or preventing HAIs, but really for how we can make it a better place to work, where not only can people provide good care, but they can do it in a work environment that's pleasurable, enjoyable, and someplace they're proud to work in. So in January of 15, which is a little over 3 years ago, we began electronic monitoring of hand hygiene. Prior to that, and I'm sure many of you know that we did direct observation, they call it, which means we would do secret shopper and somebody would watch to see if people were using the hand hygiene or washing their hands. And invariably, we scored very high, 95 to 100. And the reason why that is because it's a Hawthorne effect. If you know the cop is hiding under the viaduct, you're going to go with the speed limit. And people are responsible when someone's watching to do what you're told. But this is a 24/7 operation in a hospital, not for the 20 minutes we're doing direct observation. That's just a snapshot in time. So we had to do continuous monitoring. Many of you know in intensive care we often put an arterial line in. That gives us a continuous readout of someone's blood pressure versus a spot check. If you go see your doctor, you're a little nervous, you might have higher blood pressure. That's kind of analogous with the direct observation. It's not a really accurate reflection of what the continuous rates would be within the environment. So when we switched, we had to talk to the staff. This was about the same time I was dealing with a lot of challenges with staff that were resistant to change, staff that were challenging me on everything. And what I looked at is some of the staff, you look at all of the staff you had, some of the staff were really able quickly to make an adaptation. Others were sometimes been there a long time, 30, 35 years. Others were totally resistant to any type of change. And what I looked at when I looked at the staff of anything is some people will stay and become a part of the change, and other people will decide to leave. And that's not a bad thing. Sometimes when people leave, the newer people come on and the process change. I did have many staff that stayed and adapted very well. So it wasn't a complete turnover of staff. About 25 to 30% left, but the remainder were the existing staff. Now, they were incredibly challenging to me because they were all like, I always wear gloves, I'm busy, I can't do this. Another thing in an ICU is the nurses already feel that they have to police the doctors about 1,000 things. We, in our hospital, have a process which it does work, but it's a challenge, where when a doctor's putting a line in, the nurse is the observer, basically pointing out, you need to change your gloves, you broke sterile technique, you need to do this, you need to do that. And it puts us in a challenging position, but it is protective to the patient. So the nurses felt when we were adding hand hygiene monitoring, that would be another thing, that they would be responsible to hold other people accountable, which they do. But we had to give them a mindset of, again, it's all about protecting the patient and doing our job, and that our job is to monitor them 24/7 when we're there. So it definitely was a challenge. When the hospital came to me about it, unfortunately, I've always been kind of an A student. I thought, 75, C's get degrees. This is going to be easy peasy, no problem. Then I get my first score of 29, and I'm totally deflated, and so is everybody else. So realizing you were doing the direct observation and you were 95 to 100, which was this inflated number, obviously, and then you get the real number of 29, and you feel like, okay, now you realize this is a marathon, not a sprint. It's going to take us a long time. So if you look at our numbers, you can see over the course period of time on the slide that it took quite a while. I mean, we made some direct headlines in the beginning, and then it took a long process before as the change process took place over the 4 years. We've been 3.5, 4 years. We've been working on a culture shift within the unit. So, but I think I want to reiterate that the culture change is what actually drives it. It's not strictly related to. I mean, the hand hygiene is the outcome. The culture change is actually how you achieve those goals. So again, we looked at all of the things you run into. The negativity, I'm too busy, how will we get there? We'll never do it. I'm already wearing gloves. Why do I have to make everybody else do their job? They should just do it automatically. Lots of resistance to that. And you just slowly chip away at it. I always tell people in my relationships with the staff is that's how you handle each conversation. There's going to be challenges in your personal relationships as well as your work relationships, but you're continuing to build that forward partnership as you move forward. So to me, it's all about the staff. I started with the ACN's healthy work environment to see where we are going and where we could go. When we meet their needs, they meet our needs. I'd meet individually with each and every staff nurse. What can I do for you? How can I make it better? Is there anything you need? And then listen to them. They have lives outside of here, and it's a work balance situation. But if you're happy and can meet the needs of your personal life, then you're a better employee and happier in your life. So small things. It could be a lot of our nurses it's a female-dominated profession, come back from maternity leave, and they wanted to work the weekend so they could have someone to watch their children. Well, we made an agreement with them, or as the individual cases, case-by-case basis. So as you get the hours that you want, you're a happier employee. Do you have enough staff on your unit to meet the needs of hand hygiene? So listening to what their concerns and needs are, as we began to listen to what their needs and concerns are, then I would bring up issues within the unit, and it became a reciprocal agreement, a partnership. And one nurse said to me, and it was an aha moment for her when I was talking about hand hygiene. She goes, well, if it's important to you, it's important to us. I'm like, wow, that was a really powerful message. I realized then that I had to tell them why it's important to me for our patients, for the protection of our patients, and we make it clear to them of the importance of what we're doing. I always tell people about hand hygiene. It's not like in nursing you can rush into the room and do CPR or defibrillate somebody and instantly they get better. That is the Hollywood moment, and we do that occasionally, but very rarely. Most of the time, we're the unsung heroes in that we're doing the small thing that protects the patient. And think about this. Think about a 25-year-old nurse having to talk to a 40 or 50-year-old attending and let him know that he hasn't washed his hands, how challenging that might be. So that takes a lot of courage, and it takes a lot of internal sense of satisfaction and a pride and ownership of what you're doing in your job. So I really believe it's the ownership of the unit. I say it starts with first happy staff, then it moves to engaged staff, and the third step is ownership. Right now, today, they're taking care of intensive care patients, making a difference, and I'm here, 1,000 miles away. So I realized that it wasn't about when I'm there. It's about them being 24/7. It's not how well it functions when the leader is there. It's how well it functions when we're not. So they need to drive the change. They're the ones there 24/7. So what we've seen is a huge culture shift. They began to support each other, less turnover, the same consistent staff, and all of a sudden all of our quality indicators improved. I'm proud to say that we haven't had a central line infection in 2.5 years. We haven't had a transmission of a C. diff in 2 years. These are incredible numbers. It's very hard to link that directly to hand hygiene, but you can tell that there's some component of it that has to be within that. Recently, she mentioned we received a beacon. For many of you who don't know that, it's like the Olympics of ICUs. There's gold, silver, and bronze, and very few ICUs have it, and we were lucky enough to receive a silver award this year for our quality, and it's an incredible accomplishment, and it's never been done at the UFC and the entire existence of time they've been there, so that's a very huge process. One of the ways that we've really helped with the direct hand hygiene situation is we've partnered with infection control and our hand hygiene team. We do a brief 15-minute call once a week. We talk about where we are with our weekly rates and our current rates. We also talk about our challenges and our opportunities and also our strengths that week. We have multiple ICUs, and all the ICUs are on one call, and all the general floors are on another call, so that we're comparing like entities, and then you can share your ideas and discussion. We first started this probably the first couple of weeks. Our unit was the unit that came up with the hand hygiene champion, and we later changed the wording to sheriff, and I'll kind of explain that why later. But what it means is that someone each shift would be responsible for reminding the thousands of people that walk through the ICU that would take ownership. Much like if people are in a family, everybody has a job after dinner. Someone empties the dishwasher, somebody sweeps the floor. In the ICU, we assign everybody a task. Someone checks the crash cart, someone checks the monitors. This person's job is to assure hand hygiene for that 12-hour shift. Then we have a brief huddle at the end of the day, and they report out on their scores and how well they did, what their challenges were. Sometimes we have dying people in the ICU, and then we have tons of family in and out. It's very hard to tell someone who has a dying relative to be sure to wash your hands to protect the other patients, when they're going through this crisis. So there are some huge opportunities and some challenges when you work at an ICU. Now, in these calls, all the unit leaders are there from all the ICUs. In addition to that, we also engage the staff, have our champions there, talk about it. Once we started the champions in the surgical ICU, it spread to the other ICUs. And so I always say imitation is the highest form of flattery. So if someone takes your idea and uses it, it helps more patients and spreads the positive responses throughout the building. So that's one of the ways we've shared all our good ideas throughout the hospital. This is kind of a busy slide, but it kind of basically looks at a lot of trial and error. What we did, we got together with unit-based staff. How could we work on these processes? We go up and down. Some things work, some things don't. Some things transiently work and then go down again. One thing we tried, which did work, but it was too challenging for the patients. We had a little monitor like outside that would say, as you walk across the threshold, wash your hands, please wash your hands. And it was irritating to people trying to sleep for that to go off 30,000 times a night. So even though something works, if it doesn't meet the other needs of the patient, it's not necessarily something you can do. Now, something that works in one area might not work in another area. But we often stole from the operating room. There's a little bar that says you can't cross this line in the operating room without the hat on, the booties, the gloves. We tried that as well, and that was very successful. So you have to do trial and error. What works in one area might not work in another. But again, sometimes it's just letting the staff see what's working and see how it's successful and sharing that with everybody else. So tons of different ways you can look at hand hygiene. I shamelessly lose my little dog. She's 3.5 pounds. And what I've learned about this is in relationships, you have to share it with people to have it. We share our lives with people. I share stories about my dogs. People who have little children or whatever. When you do that, you humanize yourself. You want to engage with people on a level that they can understand. We had lots of issues with our physicians, so we started to have covered dishes and invite them to it and say, oh, we're having a Mexican day, we're having a special day for this. Celebrate all things in the unit, like someone achieving a degree, somebody having a baby. Those are successes, and those, when you humanize yourself and bring yourself into the relationship, you're more apt to be forgiving and accepting someone. So when the nurse then has to tell the doctor that he broke sterile technique, he already sees her as a person and doesn't get easily upset. So those relationship building has hugely impacted us. The other thing I've learned about advertising is whenever you put like a cute little animal or something, it's very visible to visitors. When I put this in my unit, everybody asked me through the hospital, can you share the picture? Because they noticed visitors were more attentive to it, little children. And so sometimes if you look at advertising, you'll find a good-looking person, a little animal, a child. That's very good for marketing. So use whatever you have to make yourself successful. And one of the reasons we call it a sheriff is most people feel in nursing that we're always policing the doctors, and they said they didn't want to police the doctors. And I said, well, let's call it a sheriff because a sheriff serves and protects in more of a small town kind of flavor versus a policeman with a gun versus we're protecting our patients from HAI. So the sheriff really works. And the staff actually have a little sheriff badge that says hand hygiene sheriff, and they wear it when it's their responsibility, and they pass it from shift to shift. And it's been hugely successful. It seems like a small thing, but people are like, they see that, and they're obedient to that. We do a lot of just-in-time coaching because we have thousands of employees. You can imagine there's a lot of turnover, different groups of doctors pretty much every month. So one of our nurses, and I always make it staff-driven, meets with the new group of doctors and gives them the lay of the land, the rules, don't touch our ventilators, please wash your hands, all that. And they give them a little bag, and it's got aspirin in it and antacids, and it says surviving the SICU. So they make a joke of it again, and the physicians love it, and it engages them, and it makes them more responsible. So that's a benefit to us. Again, using humor, using whatever you have to build those relationships. What I tell the nurses is you can tell the doctor something in a nice way. You don't have to say, you didn't wash your hands in a nasty way. You can like, remember, you're protecting the patients, and do it in a positive way. Anytime you have any conversations with anyone, when you say, I'm calling you because I'm concerned about our patient. When you lead with that, lead with the patient, you're creating, it's our patient, a relationship, and it's important to all of us. That's a huge initiative. It might be semantics, but just like we do not call a float in our unit a guest. If another nurse comes from another unit, we call her an honored guest. That same nurse that drove her car into the viaduct says she loves to come to our unit because she's treated with such respect. They make sure she gets first choice of her patients. She goes to her own unit for lunch, treated with kindness and respect, because there's a reciprocal agreement in being a guest. You come to my house, you bring me a bottle of wine, you compliment my decor, I give you a nice meal. There's a guest-host responsibility. It's the same thing. So again, it's all about partnering with people and making sure they feel that way, treating people the way they want, the way you'd want to be treated. So that relationship building is huge. All of the messaging thing is done from as much positivity. We have quality representatives that come, all of the messaging to the staff. So we live in a multi-generational, people text. So we text people, we call. The secretaries are able to text all the nurses on their phone saying, the doctors are coming around. Everybody be responsible for hand hygiene, reminding them about that. Or we have a new admission. Everybody be careful. We know where our weak spots are during admissions, during codes, during end-of-life processes. So whenever we know that, we're keyed into that. Sometimes we even station one of our clerical staff at our hand hygiene device to assure that she's got a little hand clapper and she holds it up so it's quiet, and then everybody who walks through does it. Sometimes we also assign, we have rounds of doctors. The MICU comes through, it looks like who is the brass band. There's like 20 different doctors and people with them. So we assign one person with that group. Sometimes it's the attending, sometimes it's the medical student. But that one person has the hand hygiene signal, and they're responsible for minding everybody on entry and leaving. And it's almost like you look at it like a duck with the chicks behind it. As one person does it, they all follow behind. People don't want to be the one not following the rules. So that's one of the initiatives we've used as well. Lots of different education. People say, well, I don't read my emails, I don't read my text. Well, we put a go and no, a bathroom wall education. It's kind of funny because everybody goes to the bathroom. So we looked at where else can we impact people with education, because you can't say I don't go to the bathroom. So you can't say you missed that education. So visitors are a huge challenge in an ICU. They're just a monumental process. But when we meet with them for the first time, we talk to them. We talk to them on the level of lay people, not medical people. And we say going in is for your loved one, is coming out is for you. It's a simple concept. You're protecting your loved one, and you want to protect yourself. It's a hospital, and we've gotten some good results for that. We have signs in the room. We also put it on the backs of the visitor passes. Anything you can multiple. Sometimes people say you have to hear something 7 or 8 times before you get it. Additionally, when people come in and they've gotten the shock that someone's in a car wreck or someone's had a stroke, they're at such a high anxiety level that you might tell them the first time. I said, I told them an hour ago. That doesn't mean they're aware of it, or they're not deliberately trying to not listen to you. They're just at such a high anxiety level, it's not sunk in. So it takes multiple times, multiple reminders. That's why we use our clerical staff to help do with that. Again, I always remember some of the people that take your information and go somewhere. We have everything scanners, so we scan everything for the protection of the patient. We scan ourselves, scan the medications, everything's scanned for safety, which is good. But that means we have people to service the scanners. One of our gentlemen that comes in, he's in IT, he's not in the medical profession. And I noticed him going from room to room, check the scanners without using any of the hand hygiene. And he said, well, I'm only touching the computer. And I go, that's the same computer the nurses are touching and then touching the patient. So anytime you touch anything in the room, the scanner, which the nurse touches the patient's wrist, puts the patient at risk. And then I said, so you are a part of preventing infections. And he said he took that information and he's religious about it. Every time he goes in a room, he wipes down the scanner. He's very religious. And I felt like this was a person that spread this information throughout the hospital to all the people in IT. So then I thought of an idea as like, have a champion in every department, whether you work in food service, transportation. These are people, so when they have their huddles and their staff meetings, they can say, this is how you, who work in this department, can impact infection within the hospital, throughout the hospital. So remember, it's not just our medical staff that are in and out of the room. It's a lot of people that touch the patient, and anybody that touches the patient puts the patient at risk. So again, we always have to tie everything back to why we're doing what we're doing. Most people have had an experience maybe with a loved one or relative. I personally have had a relative that had an HAI infection and subsequently died, so it's near and dear to my heart. Again, when you share that information to people, they're much more believable. But remember, you can't see infection, so it's something that you have to bring up clearly pretty much each and every day. Again, you can look at the results. Again, we've looked at CLABSI, CAUTI, C. diff, and had a huge impact on those. Now, again, it's hard to tie that directly to hand hygiene, but it is one of those indicators. And also staff holding people accountable. One of the side byproducts we noticed is we also had a very low sick call rate. And staff said, well, that's because you're so good about giving us our time off. And I go, but I was good about giving your time off before we implemented this. So what we felt is we had nobody... None of the patients were calling in with colds and flu as frequently. You can't tie that to it exactly, but that is one of the ways we transmit colds and flu. So we have had a very low sick call rate as well. So these are some of the ways that we've looked at how the outcomes. But to the staff, not working short because their coworker is sick is huge. So then they can feel they can deliver better care. Always bring back how it's going to benefit the patient and the unit and the staff. So that's always important. Now, this is a huge slide, and it tells you a lot of information. You can see where we've gone from the beginning, which I said was terrible, was 29%, and how we've moved and what process we've done to bring that about. I do say that it goes up and down, and it's recently, as of May 1st, we added the trauma patient, and that's a new experience for us. So again, you're going to have challenges, much like you have challenges in your personal relationships. It ebbs and flows, it goes back and forth. So you constantly have to keep it on the radar and keep the process moving forward so that you know. It can't be something you forget. That's why we meet every week for our brief call. So some of the things you notice in a hospital-wide improvement with just a small improvement in hand hygiene, only 1% of the number of MRSA and C. diff. To the hospital, which of course the bottom line is money, this saves a ton of money. And PPE as well as caring for those patients with those infections. And this is a quote that really kind of why I like to sum up my leadership. I think that leaders become great not because of their power, but their ability to empower others. Because I do work in a 24/7 operation, it's something that they're there all the time, saving lives, making a difference. Constantly have to remind them it's the big things as well as the small things, which might appear small like hand hygiene, but overall can make the difference in a patient surviving their disease process, preventing infections. It's a matter of, I always make a joke, if you're going to be a transformational leader, the first person you have to transform is yourself. So I think it's important that you practice what you preach. So if someone ever tells me I'm very religious, because I'll take the time, I go in and interview all the patients, and the first thing I'll do is use the hand hygiene, and I'll say to the visitors, well, I use the hand hygiene, and I encourage you to remind staff and do it yourself when you're coming in and out of the rooms. So our journey started with hand hygiene, but really it was about the culture shift. And for me, huge benefits to me beyond, which were great, the hand hygiene and improvements in all of our quality indicators, but also I had a hard time recruiting people now, and I rarely have a job opening, but the last time I had a job opening, I had 50 applicants. They were literally stalking me for a job. So that was really a very positive thing. And I mean, word of mouth in a hospital tells the telling tale. If people want to work for you, it means you have a high reliability, a positive work environment. And people enjoy coming to work, so that's always a positive thing. So, again, I just want to tell people that it's really about keeping the staff driven, keeping them aware. We put up, each week we put up a graph, and whoever has the highest hand hygiene sheriff award for the week, we give them a free lunch. We talk about the positives that we're doing. We're constantly giving praise and encouragement to the people. As people respond to positive affirmations. You know, some people think people work for money, and of course we all need a job, and so we do work for money. But there's a lot of people, money isn't the only thing that drives us in a job. I don't think Bill Gates or Oprah Winfrey, they need the money. There's something else driving people, and it's a sense of inner satisfaction in what you're doing. So we save lives for a living and working with patients. So constantly letting people and reminding people of that their job has huge value, and it makes a difference, that makes the difference when you work with people. I think that at least that. And that's the authentic part of leadership. This is what really drives change. So for me, I think telling people about what they're doing and how important it is makes all the difference, how the successes they're having. And I think that's about it. If you can answer any questions you might have.